different kind of questioning here. Last month, the Centers for Medicare and Medicaid Innovation, CMMI, it's a brand new outfit. We've already got a brand new acronym. They proposed sweeping changes to how we pay for prescription drugs under Medicare Part B. This is under the headline or under the heading, we need to do good things in behalf of mental health, but we have to also prevent bad things from happening, and I'm concerned about this center. I know many of my colleagues on this committee share my concerns with how this demonstration, quote, could affect patients' quality of and access to care. As the president of the Kansas Medical Society described to me in a letter just yesterday, this demonstration, quote, will force Kansas Medicare beneficiaries with serious, sometimes life-threatening conditions to participate in a CMS innovation initiative, disrupt their treatment processes, and impede their access to needed medications with no evidence of improved health outcomes or financial gains for the Medicare system. Most concerning for the purpose of our hearing today is the proposal's impact on those suffering from severe mental illness, schizophrenia, schizoaffective disorder, or bipolar with psychosis. It is often extremely difficult for patients with these conditions to adhere to oral medications, and as a result, many rely on long-acting injectable antipsychotics, which would fall under Medicare Part B. Phase 1 of the demonstration would reduce reimbursements for all new second-generation long-acting injectables. Let me repeat that. It would reduce reimbursements. Phase 2, CMS could decide some of these medications are not deemed, quote, high value and limit access to them. This could result in the patient going to a hospital, which could be a lot further away, especially in rural Kansas, Texas, Michigan, I don't know about Pennsylvania, but at any rate, where we may end up paying more for the same treatment. Or these patients could be switched to products that are less effective or have more side effects, which is where I get particularly concerned about the government coming between you and your doctor. This is particularly concerning for a patient with schizophrenia, as switching treatments impacts the likelihood of relapse, increasing the debilitating and lasting effect on a progressive condition. So my question to all of you on the panel would be this. Have you heard about this proposed demonstration, number one? Do you share these concerns about access for those with mental illness to appropriate medications? We'll start with you, Doctor. Oh, pardon me, Ms. Rosenberg.
Yes, I mean, thank you for promoting me.
I just
but it's
bestowed
very
that
nice.
upon you.
But I do feel strongly about this, particularly about reducing the price or the payment for injectables. As a country, we use less injectables than any other place in the world. It's a highly effective treatment. Patients and their families are interested in it, and it's harder to administer than giving someone a script. So the minute you make reimbursement lower, you're going to lower even further our utilization. That is a very big mistake.
Mr. Thomas.
Before I became the state director, I was the lead on a team that worked with people who struggled with schizophrenia and bipolar disorder in and out of the hospital and state hospital for many years. And we did a lot of outreach to them in their homes and watched them take their medication to help them. Because often that was one of their major things that led to their hospitalizations. And when the long-acting injectables, the new generation came with much less side effects than the old injectables, it was a godsend for a lot of people. They were able to get their shot and then not worry about it for a month and not have the daily reminder or the daily struggle to take the medication. For me, this is deeply personal, and I think anything that gets in the way of that is dangerous for people.
Dr. Bennington Davis.
Senator Roberts, HealthShare, the company I work for, does not deal with Medicare, and I was unaware of the proposal. And so I have learned from you today. Thank you.
Brandon Marshall.
Yeah, this is my first time hearing it, but I will say that I agree with Ms. Rosenberg and Mr. Thomas. I speak a lot from experience. My first charity event after we launched, first after I spoke and said that I was diagnosed with borderline personality disorder, and I spent 3 months at McLean Hospital. We had a charity event soon after, and there was a young lady and her family that came in, and we stayed in contact over the years. And last year, she introduced me to injectables, and her experience is night and day. You know, she was someone that's heavy sedated with medication, and this past year, she's just been amazing.
I appreciate that. I apologize to my colleagues for taking way over time. Let me just point out over 300 organizations are asking this rule be withdrawn. I agree. This is another case of rationing health care. There are 4 rationers. This is one. It already has its acronym, SIMI. And my fears are coming home to roost. We have a problem of recommendations going to proposal, going to demonstrations, going to regulations, and if they're significant, then they become statutory, and then CMS implements them, and we ration health care. That's where we fumbled the ball, Brandon. I recognize that.